I am Tom Boat. I'm at Cincinnati Children's Hospital, but I've kicked around and done a number of things, including chair of departments and running research foundations and running medical schools. But I'm very pleased to be back in a position where I can direct my attention to what I think is probably the biggest issue that we have to deal with in medicine today, but well beyond medicine, as you've heard. And that is children's cognitive, affective, and behavioral development. This is a panel that's titled Boots on the Ground, and the boots that we're planting in the ground here are going to be in primary health care. But as you'll see, primary health care has to mean much more in the future than it has in the past, and we have 4 people here to talk about what they're doing in that regard. Why primary care? Well, first of all, I think it is an accepted and probably largely respected part of our culture that people understand they have to take their babies or their children for health care, and they understand that they can go, whether it's to a federally qualified health clinic or whether it's their private pediatrician, whatever, and in fact, get the attention for their child that they need. Secondly, it is a universal access point, and there aren't very many. In fact, there is no other one that I know of for children in the early weeks, months, and years of life. And I think that that really is critical. I believe that that early interface is going to be important. I mean, we've talked about promoting behavioral health at all levels, and I agree with that. But if we don't get a good start on that process, we probably are not going to be able to influence lifelong health in the way that we should and can. And so I think that early interface is important. Enhancing life course health is something that pediatricians have given lip service to, but I think that we really have to, in fact, take hold, not only of that opportunity, but that obligation as health caregivers. And finally, let me just say that child health givers are inundated by kids with behavioral problems. It's not a matter of do we want to be involved. It's a matter of we're up to our eyeballs with these problems, and most pediatricians, most family medicine doctors, whatever, are not fully prepared and are not working with people who can help them be prepared to take care of children with those kinds of problems. So we're there. The question is, what do we do about it? So the Boots on the Ground is going to focus on primary care. And, I think that we've heard a lot about integration, and I think we're all for integration. It's a wave that's coming. It's probably more so in the adult care world than it is in the pediatric world up until now. But I think that in child health care, we're accepting that. But I think we have to think about this in terms of beyond fixing children's behavioral problems. We have to think about promoting behavioral health. We have to think about preventing disorders, and I think that we have an opportunity to do that. Let me just give you one example, because this is a horse that I've been riding. I'm a pediatric pulmonologist, and we're the ones who are in charge of sleep disorders in kids. Well, guess what? Children are sleep deprived. Their parents are sleep deprived. This is a big risk factor for behavioral problems. It's a big factor for obesity and many other kinds of health problems. And guess what? We're really not dealing with that as general pediatricians. Those are the kinds of things I think that we have to begin to embrace, number one, and in fact educate. And I don't think that, physicians or nurses or psychologists are the only ones. We have to, in fact, have community understanding that these kinds of things are really important if we're going to raise kids to have all the opportunities that they might otherwise have. So anyway, we have a really great panel here today, 4 individuals who one way or another are involved with primary care, but in very different ways. So Rahil Briggs is a psychologist. She's in the Montefiore system, Albert Einstein, but she is a leader in behavioral care, within the primary care system they have. Joe Hagan is a pediatrician. He's part of the faculty at University of Vermont in Pediatrics. He's been very involved with the American Academy of Pediatrics on creating bright futures and now modifying bright futures for the next iteration. Sarvet is a psychiatrist, a child psychiatrist, and he works in Springfield, Massachusetts as part of the Baystate system, also affiliated with Tufts. And he has been a major contributor to, and in fact, leader in the FAAP system in Massachusetts that is a psychiatrist supported consulting service for primary caregivers, very important. And finally, Steve Downs is a professor of pediatrics at the University of Indiana, a general pediatrician, but I knew Steve back from the early 80s when he was a resident at the University of North Carolina. And he taught me what decision analysis was. And it was because he came to us as an informatician. And I could never quite understand what he's talking about, but he gave me at least a start in being able to be conversant in that area. But he has developed some technologically advanced things at the University of Indiana that I think he will share with you. So why don't we start out with Rahil? I've asked them to provide you some thoughts about their context and what they're doing in this regard.
Thanks, Tom. I'll just speak really quickly, but to give you a sense of where we are at Montefiore, we're in the Bronx in New York. There are 62 counties in New York, and we rank usually about dead last on most health outcomes for children, for adults, whether they're obesity, asthma. We have about 1.5 million residents of the Bronx, and 70% of our births are to single women. I'll start there. Montefiore is the largest healthcare system in the Bronx, so a lot of those numbers are on us. And we were one of the pioneer ACOs, but as we've all talked about, that was centered almost exclusively on older adults. I've been there for 10 years and have started at the other side of this quandary, which is really on the promotion and prevention side. 10 years ago, we started our integrated early childhood dyadic 2-generation mental health program under the umbrella of Healthy Steps. And we really tried to identify families at risk during the prenatal period, start intervening with the family prenatally and then through the first 5 years of life, focused on trauma, toxic stress, the parent-child relationship, and attachment, all within primary care pediatrics. And you're quite right to say that, there are other universal systems that touch people of other ages. But if we're really talking about infants and toddlers, which is the time when it's disproportionately important to get it right in terms of brain development and future behavioral and mental health development, then the only place that universally sees infants and toddlers is primary care. Because of Bright Futures and the American Academy of Pediatrics and EPSDT and all these other systems, we have oodles of mandated visits in those early years. We've expanded from there to become a fully lifespan integrated behavioral health system in our primary care network. We have 21 practice sites across the Bronx and see about 300,000 patients each year. We have universal screening for mental health that's a part of every well visit. We have trauma screening with the ACEs at every newborn visit, and then ongoing annually in the first 5 years of life for ACEs for both parents and children. We've tried to work on the evidence base. My current challenges, even within the ACA and all that it affords us, are evidence-based intervention for pediatric integrated behavioral health is about here. We've got about 2 studies that talk about depressed adolescents, and one with some PCIT and a little bit of things here and there. But just for my 90,000 kids in the Bronx, we're really trying to work on contributing to that evidence base of what intervention will look like. We've developed 4 to 6 session short-term modules for depression, anxiety, attention, conduct, and trauma. We're working on obesity as our next one, and then substance use and misuse as our next one. Our other challenges are workforce development, and I think that's been a theme you've heard all day. If I hire a bunch of child psychologists, social workers, child psychiatrists who are used to working in an outpatient mental health clinic and ask them to go do short-term population-based healthcare for a clinic with, 10,000 kids in there, it's not going to happen, and I'll shoot my own self in the foot. And finally, I would just end with, even in the ACA, even as a pioneer ACO and the one that happened to save the largest amount of money when all the numbers came out last year, I'm talking about prevention with 1-year-olds and 2-year-olds and 3-year-olds. They don't have diagnoses. So even with the health and behavior assessment and intervention codes, if we do our job right, these kids never have a diagnosis, neither physical nor mental health, and nobody's paying for that still.
Interesting way you turned that over to me. Thank you. That's a good, you're right there. So just for the sake of everyone knowing, yes, we are brothers. Yes, we did not know we were coming to this meeting until we both told our mother, who lives in Silver Spring, we're coming to a meeting at the Institute of Medicine. And finally, my mom said to Greg, "Are you both at the same meeting?" So thanks, Marianne. I am honored to represent the Bright Futures Project of the American Academy of Pediatrics and the Bright Futures Guidelines at this group. This is the aspect of prevention that pediatricians are passionate about, because prevention is not just for physical health, obviously, it's for health. And last I looked, mental health was part of health. Bright Futures really started in the early 90s, led by Maury Green and later by Judy Palfrey. I had the honor to take it over with my co-editors Judy Shaw and Paula Duncan for the 3rd edition about 10 years ago. And we are pretty close to sending the 4th edition off to that 6 months where the printer has it and I don't get to worry about it for a while. Now, Maury Green and Judy Palfrey always envisioned health in the context of family and community. That's sort of what the pediatric vision has always been. And mental health as part of health. So perhaps, Neil, they were early 3.0 envisioners. The task really of Bright Futures and the task of my many co-editors and contributors for both editions has been to figure out how to enhance the well child care of delivery to kids, recognizing, and thanks for that pass, that it is a broader task than simply, height and weight and later on blood pressure. And to take the attitude towards health and vision in the Affordable Care Act and to translate that into work that can be done in practices, be they small practices or large institutional practices. And I'm pleased to say, I think you will be pleased as well, that there'll be an increased emphasis in the 4th edition on the social determinants of health, a focus on life course health, which is why we're all here today. We view in Bright Futures that prevention is done through surveillance, screening, and anticipatory guidance. That sort of uniquely pediatric idea that, if you're dealing with a 4-month-old, you probably ought to talk about certain things, and with a 4-year-old, you talk about different things, because you can predict, you can anticipate that the family will need guidance in that area. So there's a tremendous wealth of opportunity, but the question is, how do we suggest to our colleagues, how do we suggest to systems, what are the most effective, what are the most efficient ways to do that? Where is there an evidence base? Because we must use evidence where it exists, and we must think about what is cost sensitive. But there's pushback. I hear from my colleagues all the time, don't tell me something else to do. There's already too much to do in a well visit. Don't give me unfunded mandates. And I'm interested today, even I did hear a lot of people, sort of chasing the CPT code to chase the dollars. We all have to do that. Or the big one is, why would you ask me to screen if I have nothing to offer? And that's why I'm thrilled to be here, because we're really looking beyond just the issue of screening, but what can we do when we find something? How can we address these issues? I should close with my 3 prejudices that you should know about. Number 1, I am a private practitioner. I make decisions about what sort of care we're going to provide, and I also meet payroll. And those things are connected, okay? And in a small practice, you see they're very connected. Number 2, I'm from Vermont. Stop asking me about health reform and single payer. I wish the legislature would go home, You know, we're facing a fiscal deficit this year, and I'm not optimistic we're going to make a lot of step forward, but the movement's not going away. And yes, I personally am in favor of single payer. And finally, my wife's a social worker. She's a therapist. She sees kids. There are more therapists in Chittenden County, Vermont, than in many cities per capita. But there are very few who see kids. And this is a dilemma. And part of the dilemma relates to the fact that very few therapists take on children because they're more work. And because they have to be done outside of the 45-minute hour. And even with that connection at home, I have trouble making referrals for my patients. And this is a system that needs our work, and I'm really glad to have all these brains in the room. So thanks for having me here. Barry?
I imagine your mother is very proud of you and your brother. So I'm Barry Sarvet, and I'm a child and adolescent psychiatrist. I'm not a pediatrician, but I do consider myself to be part of the primary care system and part of the primary care team. And I actually think all child psychiatrists should consider themselves similarly. They don't all at the current state, which is one of the challenges that we face. And my career has been focused on trying to develop systems to bring child psychiatry in closer alignment with pediatrics and primary care. And so I'm going to talk with you a little bit about the system in Massachusetts that I've been involved with. I'm in charge of a program that was mentioned. It's referred to as MCPAP. It's an unfortunate acronym. It's not fast food. Has nothing to do with OBGYN. It stands for the Massachusetts Child Psychiatry Access Project. Actually, I misspoke because it does have something to do with OBGYN because we just spun off another program called MCPAP for Moms, which is focused, it's our primary prevention program. MCPAP right now is really focused on secondary and tertiary prevention, but we recognize maternal depression to be a critical area for primary prevention. And so we spun off a program called MCPAP for Moms, and we're actually partnering with OBGYN docs and adult primary care providers to try to address maternal depression. But what the project is all about, it's Dr. Halfin, oops, can people hear me? Dr. Halfin was talking about the idea that primary care providers have to have all these connections to other systems. We talked about schools and behavioral health systems and children and families and child protective services and juvenile justice, and it has to be this hub and has to connect out. And so MCPAP really is a program about connections to between pediatricians and child psychiatrists. It's a networking buddy system, so to speak, at its heart, that's really designed to try to improve access to children's mental health care by establishing a connection between child psychiatry teams and pediatricians. It's a statewide project. We've been doing this for 10 years. It's population-based. It's a socialized medicine system. Don't tell anyone. But it really it's for any child in the state, and it's for all pediatricians regardless of payer, and it's publicly funded. And what we do is that we develop teams that each operate a hotline that is open to pediatricians in a catchment area. And in order to use the hotline, you have to become affiliated with the teams, and we've enrolled 98% of the pediatricians in the whole state. So everyone's affiliated. But the program at its heart is really a liaison relationship program. So it's not just a hotline that's public and you call a 1-800 number, that you become affiliated, become enrolled with the program, and when you're enrolled, you can actually call whenever you have any kind of question related to mental health, and you can talk to a child psychiatrist. And when you talk to the child psychiatrist can give some advice, can answer questions, can see the patient for an expedited psychiatric evaluation, and can work with a care coordinator on the team to try to find services that the child needs and to try to link up the child that's being called about to services that are necessary. So it provides those three services. In addition, it also provides educational programs. We actually consider the program to be an educational program inherently because we actually consider the consultations to be a preceptorship model of training. So it's almost as if when you're a pediatric resident and you go in to see a patient, you come out of the office and you talk to your preceptor. Well, with McPAP, the pediatricians go into the office, they see the patient, they come out of the office, and they call the hotline to talk to a child psychiatrist about that case. And we try to provide case-based education. We're not doing remote control treatment because we're not seeing the patients that we're consulting with over the telephone, but we're trying to educate pediatricians about evidence-based practices and best practices to further evaluate and try to meet the needs of those kids. And so it is an infrastructure at this point. We've been doing this for 10 years. We have about 30 child psychiatrists in Massachusetts who have been involved with this program. We have 6 teams in 6 regional areas. And so we've been training a workforce of pediatricians to work within this program and to learn how to partner with pediatricians in primary care practices. It is not a co-located model. So there's a limit to how much we can do, and we also realize that child psychiatry is not the totality of children's mental health by any means, that we just provide one part of the puzzle. Many of the practices that we consult with have integrated co-located therapists, and we find that that's a wonderful synergy because the therapists who are in the practices can help sort out and do care coordination and engage with families around mental health needs, and then the child psychiatrists can supervise that and help to understand what some of the psychiatric disorders are and some of the medical treatments that might be involved. One of our goals is to reduce the unnecessary use of medication. So many of our consultations are about medication questions, and then we redirect that into other kinds of treatment plans that don't involve medication. So we're not pushing for pediatricians to become psychopharmacologists per se. We're pushing for pediatricians to be able to be empowered and be enabled to be able to follow best practice guidelines, which often don't include medication treatment. It's a scalable program. It's designed on the basis of a recognition that child psychiatry is an under-resourced specialty, and we have a very small workforce. And so it's a model that spreads over the population and tries to optimize the use of a child psychiatrist for training other people to extend the resource further, and also to try to identify kids who actually need to be routed into the specialty arena. And so we're the first ones to recognize with pediatricians that a certain kid that they may be calling us about actually needs to be treated by a child psychiatrist and not be treated in the primary care setting because their conditions are too complex and severe. But we try to rationalize that limited resource and try to direct only the most complicated and severe kids to be treated by specialists so that child psychiatrists in the community aren't all booked up treating patients who could be treated by other providers who don't have a specialized training.
Barry, thanks. I think we have to move on.
Okay, I'm sorry. I think I'll just end just by saying that we are private-public funding now because we actually were successful in getting legislation approved so that we could have insurance companies operating in Massachusetts chip in to provide the support for the program. So we become part of the infrastructure of the state, and then the insurance companies are paying for part of the program, and the mechanism is the same as the mechanism for paying for immunizations. So we're part of the public health infrastructure now, and thank you.
Hi, so I'm Steve Downs, and I'm a general pediatrician. I'm a vice chair for general pediatrics at IU, but I told Tom I guess I'm here as the token medical informatician, which means that if you've got complaints about your health information technology, I'm here to lend a sympathetic ear. So I want to talk about the system that we have built over the last 10 years at Indiana University, and it's actually based on work I did at the University of North Carolina before I moved to Indiana. It's a system we call CHICA. It's we would call it a clinical decision support system that is actually layered on top of an existing electronic medical record system. Luckily for me, it's a homegrown system, so it was fairly easy to plug the pieces in. But the way the system works is when a child comes into the clinic, the registration system notifies our system, CHICA, that the child has arrived. CHICA downloads that patient's electronic medical record, runs hundreds of rules, and selects 20 questions, 20 yes or no questions to ask that family. And those questions are displayed on an electronic tablet that's given to the parent as they come into the clinic. They answer these questions on the tablet and return it to the medical assistant or nurse when the child is brought back to be roomed. Their answers to those questions are added to the electronic medical record system. Another set of hundreds of rules are applied to the enriched data set, and 6 reminders are provided to the pediatrician. And it's not 12 reminders and it's not 8 reminders, it's 6, because that's what they will tolerate getting in a busy primary care pediatric practice. And each of those alerts is associated with 6 checkboxes with which the physician can respond, document how they've responded to the alert. And just to give you a sense, and so the way this thing works is, conceptually, is we are encoding guidelines. We get our guidelines primarily from the American Academy of Pediatrics, a little bit from U.S. Preventive Services Task Force, CDC, and so forth. But the concept here is that we can quickly ask high sensitivity, low specificity, or moderate specificity surveillance questions in the waiting room and focus the physician's attention on important, if not salient, issues that need to be dealt with for that child, and to follow those protocols for management of the problem. And to give you a sense of the scope of topics that we cover, we screen and refer for maternal depression, domestic violence. We follow the AAP guidelines for developmental screening, autism screening. We look for food and utility insecurity as part of our medical legal module. We check to make sure kids are on WIC. We screen for symptoms of school failure and follow-up attention deficit hyperactivity management. We screen for environmental tobacco smoke and use a trans-theoretical model, stages of change model, to help parents quit smoking. We check for TV viewing, TVs in the room, and that's in addition to sort of TB screening and anemia screening and lead screening and those kinds of things too. The advantages of having a system like this are not only that we can improve the quality of care, but that we're capturing data that are not captured in other systems. So I can tell you how many parents have reported violence in their homes, and what's our rate of not only what's our rate of environmental tobacco smoke exposure, but how many smokers are motivated to quit and how many are not motivated to quit, and where are they in their stages of change. I made a comment earlier this morning about prioritizing guidelines. I mentioned there are hundreds of rules that are applied to every patient. We have developed a formal, and I won't get into the details of it, formal mechanism for prioritizing what alerts and what questions are presented, and so that we hope through this mechanism to be optimizing the precious time that's given to the primary care pediatrician. We've run, I'm not sure I've got the count exactly right, somewhere between 6 and 8 randomized control trials that have been published that show improvement in the quality of care. And I'm sensitive to Dr. Kellum's comment earlier about, all we need is one more information system out in the world. So we have specifically designed it, as I said, to sit on top of existing EHRs. And we're expanding now from our own EHR, and we're working with commercial vendors to make this an add-on. Some of the EHR vendors are allowing people to add functionality on top of their EHRs, and so we're trying to move forward pursuing things in that direction.
Thank you all. So I'm going to depart a little bit from the way questioning has gone for the first part of the day. and say, I'd like to get to workforce development as we put teams together. I'd like to get to evidence production because I think that's going to be really important. But I'd like to ask you, first of all, you know, I think what's important is not that we've gotten a start, but where can we take these efforts? So what's the next opportunity or the next big step in your programs, and are there obstacles to carrying out those steps in the near future? Anybody want to tackle that?
I'm happy to tackle that
Good.
because we're
Okay.
struggling with that right now. Well, the next obvious step is what I fondly refer to as Chica for All. We would like to make this a service that's available to anyone through their existing EHR systems. And there are enormous barriers to this. We will have some conversations about workforce for healthcare, but there's also a problem with workforce in the medical informatics community, and there are not enough people who really know how to do this kind of work to spread it and disseminate it. And it's expensive to add these things on, even if you do it with zero profit. It's expensive to develop and connect these things together. And lastly, I think that the concept of meaningful use is a solid, positive move. You know, you don't just get to buy your EHR, but you got to use it meaningfully. But the rules around meaningful use have actually distracted from really intelligent, creative ways to use health information technology to do some of the things that we've talked about here. And that's one of the reasons I think current EHRs don't support what we've been talking about today.
Dreams and obstacles? Anybody else?
So we've been working on trying to grow our program both within and also to spread it. So one of the challenges with a program like ours is that it's a pull program as opposed to a push program, so to speak. So pediatricians need to call us in order to get service, and we don't push ourselves into their practices. And so it really is dependent upon practices being able to have the motivation and to be able to design the workflows internally so that they can begin to do the work that they'll need our help with. And so I think that there's enormous need for training for pediatric practices in process improvement and general mental health training, but also process improvement training so that they can learn how to incorporate attention to mental health within their primary care workflows. In terms of the external growth, we actually developed a national network of child psychiatry access programs because we have a large number of states who are developing similar models, and we're trying to help to coordinate those efforts and to help to promote them. So we have actually 28 other states who are doing programs similar to ours. And we have about 35 states in total who are members of the network. And so we're all working together to kind of help each other. Each program is funded differently. So I think one of the biggest challenges is funding. In Massachusetts, our legislature and our general fund actually funds the program. We don't have a Medicaid waiver. It's funded by the taxpayers as well as the insurance companies. But every state is different. Some states are using tobacco money. Some states are using post-Katrina money in Louisiana. And so every state is different. And it would be very nice for there to be some way of having the funding streams be more standardized across the country to try to promote these kinds of efforts.
So opportunity. Brave Futures actually has status within the Affordable Care Act. There's this little line on page 700 and something that says that preventive services will be provided according to a series of guidelines made available by MCHB. And there's only one, and that's Brave Futures. Now, that at first blush is an opportunity. On the other hand, it's a burden. And it's a good burden. It's a burden that has required us to be cost sensitive. It's a burden that's required us to think about where the manpower issues are and what can be implementable. And it's a burden that has caused us to really use evidence when it is available. Now there's the devil in the details. Very many of the things done in primary care there is no evidence for them because they haven't been studied. On the other hand, I will tell you for a fact that there's a whole lot of evidence that's evolved between the third edition and the fourth edition. And it's nice to see that the efforts of something like Bright Futures has caused USPSTF to look at more child issues, the CDC Community Guide to speak to more pediatric and adolescent-specific issues. So I think that there's opportunity, and opportunity does bring burden, but that's okay.
First the Bronx, then Berlin, right? I mean, so we've got 1.4 million people, but there's a whole bunch more just in some boroughs to our east, right? So I think that we try to think about it at a state level, and in New York State, the questions that seem most relevant to how to get this beyond just a place that was a pioneer ACO and so on is to really, we've got to move completely away from fee-for-service. New York State is a carve-out state. It's been an absolute disaster. My providers have lists this long of all the behavioral health carve-outs and each and every different rule that each one has for pre-authorization and which number you call or which website you go to. Empire Blue Cross Blue Shield, one of our largest payers in the state, has 3 different behavioral health carve-outs. I'll stop there. The other, I think, real opportunity is to redefine medical necessity. For those places that are going to stay within a fee-for-service world, we've got to really think about it. Is medical necessity enough to be the infant child of a mother with postpartum depression? Is that medical necessity for that child, for that baby? I would argue that it is, but it's not where we are right now.
Moving on fairly quickly to workforce, and I think we're going to have brief answers or points that we address to this. But in terms of workforce, competencies for doing this work in pediatrics, and I would dare say family medicine and psychiatry and probably psychology and so on, to do this kind of work is not expected by the certifying or the accrediting bodies. And my opinion is it's going to need to be if we're going to, in fact, prepare a workforce that's going to be able to tackle this huge issue. And secondly, they don't expect people to learn to do this kind of thing as a team effort and begin that by, in fact, training interprofessionally. And your thoughts about how we can go from where we are now to a more competent workforce?
Well, my first answer to that question is yes, yes, and yes, as someone else said that. There's a need to do that. I guess the only thing I would add to your comments, as it occurred to me during the day today, that we don't want to repeat the mistakes of the second half of the 20th century, where maldistribution of workforce was at least as big a problem, and still is, as the size of the workforce itself. And I think that's a problem no one has ever gotten their hands around, is how do we not only develop the workforce we need and people who are skilled at this kind of team care, but how do we make sure that they are in the areas where the need is?
I think one of the challenges in training pediatric residents, and I can't speak for family medicine, is not just training the content of a well visit, but how to do it. How to actually do the screening, how to actually interpret the screen, and then what to do when you find a positive. Because if you've learned how to screen, but no one's ever taught you what to do with the outcome, guess what? You're not going to screen when you're in practice. I think the same is true for teaching our residents behavioral health and mental health. It's not enough just to teach them, how to make the diagnosis of depression, but they need to know, how to assess burden of suffering, how to assess, the negative impact, and begin those very hard conversations with families and hard clinical decisions about who gets treated with a life self-care things and who gets treated with a referral and who needs, an SSRI, which I must say, when I started practice, I couldn't spell the different ones and didn't care, thinking I'd never need them. Well, we prescribe them commonly now because that's an important part of the treatment of some very depressed adolescents.
I think the distribution question, Steve, is so interesting. I'm in New York City. We obviously don't have that problem. At however many child psychiatrists there are in the country, I think half of them live in Manhattan. So, but that raises a different challenge. With all due respect to my pediatricians, who are fantastic, I can count on one hand the number of them that wrote stimulant prescriptions because they didn't need to, because they had a child psychiatrist in their back pocket. right? So I mean, it creates different problems. So the workforce development things that we're working on is we've got just 5 child psychiatrists for our system of 100,000 children, and they're co-located and integrated into our biggest sites, but then consult to the smallest sites. They have monthly collaborative office rounds where they teach the pediatricians. They start at what is ADHD and what would be the evidence-based treatment for it and how do you interpret a Vanderbilt, and then really start to get into the psychopharmacology of it. But my biggest challenge, again, is that we have a staff of 20 right now, 5 psychiatrists, 15 psychologists. In the summer, we're hiring 8 more. Even in New York City, I can't find people. I interviewed 150 people for our first wave of 8 hires last summer. 3 of them had experience in integrated primary care.
Just another point about workforce development is that it's very difficult to teach someone how to do something if when they try to do it, they experience failure and frustration. And so there are so many systems issues surrounding just the issue of education and training for the workforce that have to be solved at the same time. We can't wait for them to be solved, but I think that we have to pay attention to that as well. So in Massachusetts, for example, when we first started our program, most child psychiatrists were very puzzled when we said, this is the job, this is what we want you to do. They didn't know how to do it. They didn't have experience doing it, but we had a system that we developed that would support them to do it. And then they tried it, and now we have 30 child psychiatrists who are doing collaborative, consultative work. And so we need to build systems and to try to address issues of system function in order to be able to have that environment in which it's possible to train people. And then pediatrician training is another piece that so much of pediatrician experience in mental health is an experience of failure and frustration. And so if we build some supports and infrastructure around the pediatricians, then we actually can have pediatricians who are interested in learning and becoming better and better. And so a good number of our pediatricians who are involved and very engaged with our program are actually seeking out specialized training. There are different kinds of mini fellowship programs that are going on to train pediatricians in mental health, but they wouldn't have wanted to do that if they didn't have sort of some context in which they could do that successfully.
Several of you are engaged. We have about 3 or 4 minutes for our 45 minutes. Is that okay, Marianne? Yeah. Okay. We can do that. And why don't we just stop at this point and ask if there are questions from the audience? Yeah. Right, Jane?
So each of your talks was so informative and inspiring. But all of your workforce issues went only to the highest level of professionals. And I can't see, even nationally, but for sure globally, that unless there's some kind of paraprofessional wraparound in a lot of these practices, that these systems are going to work. And some states reimburse, some don't. What's your experience, your expectations? How do you see it evolving? What role do you see for paraprofessionals?
So for us, just really quickly, in our CMMI grant, there are children, and the 2 real innovations we're trying to do, one is around payment reform, obviously, but the other one is around community health organizers in the primary care settings as really being the first line, as being the person who meets with the family first, actually, and sort of makes the decisions based on the University of Washington sort of registry system and some other systems. But I think that you're exactly right, and it's an underutilized resource for us, but it's part of our CMMI work that we're planning to expand throughout the network.
And this is where I have to speak as a small practitioner. I want that desperately in my practice because it will allow me to see more in children and see them better. And I have no idea how to meet that payroll.
Not only that payroll, could you fantasize for your practice, how would you ever train and improve them over time?
That part, if somebody else could pay their salary and pay their benefits, that part's easy because we've already got in our system, in our practice system, people on staff who are doing that sort of thing with care coordination. That's not a model we'd have trouble growing, and it's partly because of the kind of folks I hang out with, thank you all. But it's a matter of being able to do it and not have it overburden payroll. I mean, like everyone else, we have kids we send kids to college. I mean, you have to sometimes say there's only so much that you can afford.
So I just want to bring us back to this whole notion of a two-generation approach and wonder how that is going to roll out over time in integrated primary pediatric care. You know, and I don't want us to have to get too bogged down in the weeds of things like the, you know, the record and how information about parents gets captured in the record and some of the really important ethical and clinical issues that we're going to have to face. But I would appreciate your thoughts on how do we really address some of the core parenting and parent mental health issues that affect child health and child mental health in primary care, and where do you see the next great thing in that area?
So I can tell you on our end, without getting too far into the weeds, because that took us about 3 years to get through, where things would get documented and whose chart and how it would happen. There's really no reason why parents can't be seen in our pediatric clinic. You know, the logic was always that they have to go upstairs. Why do they have to go upstairs? Because that's where adult medicine is. Why can't they be seen here? So we have mental health treatment with psychologists and psychiatrists within peds just for the parents and just for the adults. They come in through that same pediatric door that's non-stigmatized and universally accessed, but they see their own clinician. The idea is always that that work becomes dyadic, but sometimes the trauma is so significant that it needs to be individualized in the beginning. I think our next moves and our next steps is really to take advantage of more of a peer network and to do more peer support and group-based interventions around parenting in the primary care center. We haven't figured out how to make that work very well for school-age and adolescent kids. I'll be very honest with you, because that's not where those families are, but it's where the young kids are. So I think for us, that's the thing to figure out next.
From an IT standpoint, we've been unabashed about recording information collected about the parents in the patient's electronic record. We just don't worry about that. We don't have quite the same treatment for all in that environment, with the exception of very few things. So I would love to see that developed in our environment. But the IT issues, we just haven't even worried about it. If it's relevant to the patient's health, it goes in the record.
I think that we've probably completed our 45 minutes. If there are no other questions, I think you have an idea that we've gotten a good start in places. We've got models. We have to perfect the models, and we have to disseminate or scale. But it's a great start, and thank you for sharing your experiences with the group.